You know, I'm a sociologist, so I'm not going to present. You saw a lot of trend lines, bar graphs, you know, forecasts yesterday. I don't like that kind of stuff. It sort of creeps me out a little bit. You know, I deal in people. I like to study people. I like to study dynamics in the workplace. I like to study what goes on in organizations. In the healthcare system that's coming, access is going to be everything, okay? We've sort of played around for the last 10 or 15 years, the quality movement. You know, we've really focused on quality. I think access is going to now become the tsunami that envelops us all. And quality, you know, will still be extremely important, but we're going to have to establish contact points to get people to be able to get into care. I mean, I work now in a state, Massachusetts, that's been grappling with this for, you know, 5 or 6 years, okay? And they're still trying to get a handle on it in terms of getting people in to see primary care doctors, getting wait times down. They're the bellwether for the rest of the nation, okay? So, and the third point is, when we try and think about workforce and physician shortage, I think there's a value to understanding what's happening on the ground. I think more of us need to get inside these organizations, these delivery sites, you know, whether they're hospitals or ambulatory care clinics, whatever, and really understand what kind of work is going on, how is work changing in healthcare, who can really do that work now, and who can't, okay, and how should it be done? These are 3 questions that we're trying to answer from the macro level. You know, to put systems in place and to rationalize and standardize and bring technology in, and that's all well and good, but at some point we got to get in and really look at how is all this stuff playing out on the front lines. We have an aging physician workforce, okay? 1/3 of primary care docs nationally are over the age of 55. A lot of them are going to start retiring soon. I can tell you, talking with a lot of them, my own feeling is a lot of them wish they could retire now. That's how a lot of them seem to feel about the system they're in, okay? Remember, these older primary care docs, you know, they grew up in a system that was very different. And if we want to fool ourselves and think that a lot of them are happy about what's happened, they're not. And so they're going to be out migrating. We're going to have some new ones coming in. But remember, the new ones are going to be very different, all right? I like to tell this little sort of anecdote. You know, I'm a Generation Xer. You know, I'm in that nether world between the millennials that get all the attention and the baby boomers that get all the attention. I never got any attention. I'm the lost generation, okay? So, and I'm proud of that in a way. You know, I missed the baby boom by 1 year. I was born in 1965. I guess the baby boom technically cut off in 1964. And I always said, well, I feel proud of that. But when I look at the baby boomers, to sum up the differences in generations, you know, I wake up in the morning, and when I think like a baby boomer, I think, I got to go to work. I got to work all day. I got to contribute. I got to work really hard. I got to balance everything in my life. But I got to work, and I got to be committed to my work, and my career matters, et cetera, et cetera. When I wake up as a millennial, I go, let me have a cup of coffee. Let me think about what I want to do today. I'm going to work, but, you know, I really want to kayak, or I want to... You know, I want to hang out a little bit. I want to see my friends. I want, you know, and I want to have a really good job, and I want to have a really good career. But that's not everything to me, okay? Hence the difference between the generations. That's going to seep into the physicians of tomorrow will be very different from the physicians of today. Not necessarily in a bad way, but they're going to be different. So EMRs, same thing. I mean, you know, EMRs, I've done some studies where EMRs, a lot of doctors have talked about, you know, feeling that what they look at mostly is cut and paste stuff, that they, you know, specialists send them notes and they see the same note for 4 different diabetics from the same specialist, and they go, wait a minute, which one is the note for? And to them, they feel like there's a real voltage drop of expertise and information that's being transmitted to them. That's potentially a de-skilling effect, okay? So, and when you look at the business model in something like primary care, I mean, what does a primary care practice really do now? You know, what's the complexity of care that they deliver? And so these things we have to understand. These are things that are happening at the micro level, but they are changing the way the workforce, the physician workforce, you know, they're changing their ability to perhaps do certain things or not do certain things in their work. I will tell you, though, I'm doing a medical home project now, grant, and looking at medical home implementation for older adults, and there I can see the primary care doctor mattering an awful lot. Because the older adults are really complex. None of them want to use technology. They want to talk to their doctor on the phone. They don't want to talk to the nurse. They don't want to talk to the medical assistant. And what the doctor will say is, you know, I'm the one that they trust. I'm the one. Now, again, that might change 10 years from now with the new batch of older adults. But right now, technology isn't helping doctors deliver medical home care to their older adults. Doctors are helping doctors deliver medical care to their older adults. What you're going to see is technology use among the workforce remaining flat, okay? You see a lot of studies now coming out on EMRs that show doctors, you know, providers don't use them the way we want to. They don't have the time to use them. The work environment is still not set up for physicians especially to use EMRs in the way we want them to, for example. So what you're going to have is health IT being used mainly for what I call organizational level analytics. You know, being able to track populations, being able to look at patterns of care. So I think the provider level embrace of technology will remain ambivalent at best, okay? And that's going to slow value creation if we think technology can actually make a doctor's work life easier. What I see now in my own world is that it makes their work life harder and more complicated. So we're going to need to think about that. I think it's entirely possible that we're going to have a patient backlash coming with the whole issue of technology. I think some of the innovation we call innovation in healthcare is way too slow for the younger generation and way too fast for the older. I mean, I teach at a university, and I can tell you, you know, and all of you have kids, I mean, a 17 or 18-year-old boy, they're so far ahead, I don't even understand some of the stuff they're talking about when they talk about the technology they're using, the apps, how to do this, how to do that. And when we look at healthcare, we think we're doing so much technologically. You know, if you probably talk to a 17-year-old, they'd be like, dude, well, you know, you can do better than that. Come on. You know, whoa, I can access my EMR through the computer? Whoa. That's so 2005. I mean. So, you know, I think we got to realize that if we really want to use technology, particularly for the young cohort, we're actually going to have to speed things up and innovate even more.